And I was saying that the abdomen is not as fixed a structure as some of the other structures that we've been looking at. So it's because it's so movable and it's so vast, right? The intestines are not fixed in one place. They're pretty much, you know, flexible and movable. And so if you're not doing well with some of the more fixed structures, this week may be more of a challenge. So if you haven't been going into the lab, this may be one of the weeks that you might want to just take a step in there and again, look at a more focused review of some of these structures, especially the intestinal structures, okay? And that'll make a little bit more sense as we go along, okay? So we're starting looking here at the anterior abdominal wall. And this is pretty much the outside of the abdomen after we remove the skin and all that fatty tissue, the subcutaneous fat. And so what we get down to is called the rectus sheath, okay? So the rectus sheath is this connective tissue structure here that's covering over our abdominal muscles themselves, right? So we've got the main abdominal muscles, the rectus abdominis, kind of running longitudinally here. And then we've also got some of the other abdominal muscles, the obliques, so the external oblique, the internal oblique, and the transversus abdominis, which are running in the very same way that the intercostals did. So they're kind of deep to each other, and the orientation of the fibers is quite different. Okay, so here I've reflected that rectus sheath, so we can kind of see it peeled back here, right? And this is the rectus abdominis. So again, this longitudinal muscle, this is what we get from, you know, when people have their abs really defined, this is the muscle that's been toned and quite defined under the skin. And so it actually has these compartmentalizations here, which is what forms that six pack that you probably have heard of or know about. So when these muscles get really defined, that's what we're seeing underneath the abdomen. But these are the main core muscles, the rectus abdominis, and they're really at the central part of the anterior abdomen. Okay, and what we're showing here is on the left side, but if we were to peel back the rectus sheath on the right, we would see that longitudinal layer there as well. Now, here is just a snapshot, sort of a section of the obliques. And this is just to show you the depth of the obliques as well as the orientation of the fibers. So the externalmost, the outermost oblique that we're going to see is the external oblique, which has very similar orientation. It's got fibers running down and inward, sort of like that hand in your front pocket analogy that we gave for the external intercostals that were in the thoracic region, okay? And then when we peel that layer back, so I'm going to move on to the next slide here, retracting or peeling that layer back, we're going to see the internal oblique. And I wish I would have changed my view here, but the internal oblique have an entirely different orientation. They're going to be like hands in your back pocket. So sort of down, but inward in terms of their orientation there, okay? And then the third depth here is the transversus abdominis. And this has pretty much horizontal direction of the fibers there. Okay, so this is that internal oblique that's been peeled upward. Here's the external oblique that's been peeled that way. And then the internal, the deepest layer of the abdominal wall laterally is going to be that transversus abdominis. Okay. All right. Let's get down into the posterior abdominal wall. So that's a look at some of the anterior abdominal wall structures. And we would have to peel that away, remove all of the abdominal contents. So pretty much remove the visceral organs, remove the peritoneal, that fatty connection that I'll talk about in a minute, and kind of push those off to the side in order to see some of these deeper abdominal structures here, okay? And mainly these are muscles that we're looking at. So what we're seeing here is the psoas muscle. So this muscle that goes from the vertebra, so here's the vertebral column centrally located. Here is the psoas muscle, and it goes all the way down, crosses the pelvic brim, and it actually attaches to the femur, okay? So we would have encountered this muscle when we looked at the lower limb, the thigh muscle. It's actually one of the hip flexors, but its origin is all the way up here at the level of the vertebral column. Okay, it's actually also forming the bed for the kidneys. So this is where the kidneys would be. I'm actually holding one of the kidneys here in my hand just to show you that where that relationship would be. And so the psoas muscle is going to be in close contact with the kidneys on either side, okay? Next to that, we have the QL, the quadratus lumborum. And this is a shorter muscle. It's originating from a little bit higher up, as we can kind of see here, than the psoas muscle. And the quadratus lumborum is a main spinal support muscle. It's going to help support the spine, really important in posture. And it's actually going from the bottom of the last rib and down to the top of the pelvic cavity. So although it's kind of hidden with some of the vessels and the connective tissue here, it's going to attach to the medial aspect of the iliac fossa here, the iliac crest. Okay, so its orientation is going to be a little bit different than the orientation of the psoas. The psoas is going down medially, all the way down, crossing the pelvic rim toward the femur. The QL is sort of laterally located here. And because it's so deep, it's the deepest posterior abdominal wall muscle, the QL that is, it's a little bit harder to appreciate with the psoas intact. Right, so I'll point it out a little bit better on another image coming up. And then the other muscle in the region here is the iliacus. And the iliacus is this fan-shaped muscle, okay? It actually sits in the iliac fossa. So the iliac fossa is that sort of basin-like region that is within the ilium, the top part of that pelvic bone. And again, it's fan-shaped, so it kind of, fans out here towards the iliac crest and then comes in more medially towards the central part of the pelvis, okay? So again, we've got the psoas here, we've got the QL here, and then we've got the iliacus forming the iliac fossa there. Okay, so here's what these three muscles look like with a little bit less stuff in the way, just to show you how they differ in the orientation of those fibers. So here's that QL going from the bottom of our last rib down to the top of the pelvic brim, right? Here's the psoas going from the vertebral column, so an entirely different origin, but it goes all the way down to the medial aspect of the femur here, right? It's actually a low part of a lower limb muscle that we talked about, which is the iliopsoas. And the iliopsoas is actually that connection of both the psoas and the iliacus, okay? So the iliacus being the one that's sort of fan-shaped, sitting in the iliac fossa here. And when the fibers of iliacus join with the fibers of psoas, this is where we get that iliopsoas muscle that we talked about in the lower limbs, okay, one of those hip flexors. And then from a posterior view, again, you really want to appreciate the very depth, this is the deepest muscle here of the quadratus lumborum. Okay, all right. Let's move down, look at some of the inguinal structures, the inguinal region. And the inguinal region is this lateral groin region, okay? It is formed by the inguinal line. So the inguinal line is this plane or this imaginary line that divides the abdominal region on top, right? So this plane here, separating the abdominal region and the lower abdominal wall from the lower extremity and the thigh, where that thigh really starts. And that's the inguinal line. It's going to be formed rather by the inguinal ligament. So the inguinal ligament is this structure, and we've kind of opened up the ligament to show the structures that are inside, but the ligament has these structures inside. It's got the testicular vein, it's got the testicular artery, it's also got the vas deferens here. Okay, and so those structures are within that inguinal ligament that's traveling within this inguinal region here. And then we've also got the inguinal triangle, which I don't think is on your list, but the inguinal triangle is where we have those femoral vessels. So these should be familiar to us at this point, the nerve, the artery, the vein that are found in this region that are really going down toward the lower extremity, but it's also part of that, what we call the inguinal triangle. Okay. Now, because this ligament has to pierce the abdominal wall, we end up having two openings, right? We have the superficial inguinal wing as well as the deep inguinal wing. So where the ligament would actually pierce the abdominal wall, this is called the superficial inguinal wing, okay? The superficial inguinal wing. And that is where the ligaments would pierce. Now, it's kind of difficult to explain the anatomy here without talking about the embryology behind how these structures develop. So essentially for males, which is where these structures are more important, more relevant, males develop their testes actually in the abdominal cavity. So the testes don't grow or develop down in the scrotal sac where they end up being located, during life. They actually develop up in the abdominal cavity, actually toward the posterior abdominal wall. And, between late fetal period and eventually within 1 month of birth, the testes actually descend through this structure that we're talking about here, through this opening, and they drag these structures with them, right? So the testicular artery, the testicular vein are actually structures that originated coming off of the abdominal aorta. And when the testes was descending as a part of that fetal development, it's gonna use this as a route to exit the abdominal cavity and actually descend to where they're located down in the testes here, okay? And so that's kind of the embryology behind why we have this structure piercing the abdominal wall and why we have these, these contents within the inguinal ligament that are then being dragged down along with the testes, okay? So what we're seeing here, that superficial piercing of the abdominal wall is called the superficial inguinal wing. And then we're not able to clearly locate or see the deep inguinal wing, but this is actually where the testes pierces the abdomen deep or internally, right? So because it's in the abdomen, it has to pierce the abdomen internally first. That's the deep ring. It's going to travel through the abdomen, let's see, from here to here, and then it's going to pierce the anterior wall and descend into the testes. That's going to be the superficial ring, okay? All right, so enough about that. Let's look at some of the other structures in this region here. There is the penile suspensory ligament. So the ligament that helps to anchor or attach the penis to the anterior abdominal wall. And I'm I can't speak. I'm kind of holding it up here with my finger. So this is what helps to keep the penis attached to the anterior abdominal wall. We also have some sort of, connective tissue that's helping to anchor there as well. Laterally, we can see those inguinal structures that I showed previously. So the vas deferens, the testicular artery, and then the testicular vein there as well, which are the contents of the inguinal ligament. Okay. In this structure, I think we're just showing the same thing, but just showing that superficial ring on the other side. So the superficial ring here, superficial ring here. We've got the inguinal line here, right? Inguinal line. And then we've got the contents of the inguinal ligament coming through here. There they go. Okay, let's get into the actual GI organs themselves. So we'll talk all about the abdominal wall, the abdominal region, and associated contents. Let's get into the actual abdomen. Now, when we open the abdomen, the first thing that we usually see is this fatty connective tissue. This is called the omentum. The omentum is actually, it's pretty abstract and sometimes difficult to visualize, but it's actually a modification of the peritoneal cavity. So if we think about those double-walled serous cavities that we looked at that were lining the lungs, lining the heart, right, that pericardial sac, we see a similar serous cavity lining or encapsulating the abdominal visceral organs. And so the front part of that fatty connective tissue, which I'm kind of holding here in my hand, this is called the greater omentum. Okay, and again, it's just a modification of that peritoneal cavity. So when we talk about the peritoneal cavity, we think about it the way it is intact in the body, but in actuality, when we open up the abdomen and we start removing those visceral organs, it's very hard to keep that structure intact. We sort of disrupt that double-walled membrane and we disrupt that cavity. So the parietal layer of the peritoneal membrane, of the peritoneal cavity, would be this layer that's intimately attached to the posterior aspect of the anterior abdominal wall, right? This is the parietal layer. Whereas the visceral layer of the parietal cavity will be what I'm holding here in my hand. So that omentum or that omental sac, okay? And then within that visceral layer, there are these modifications. So the two main modifications that we're gonna look at are the greater omentum, which is the largest part of that fatty curtain. That's kind of the best way that I find to describe it. And then we also have the lesser omentum, which is usually located above the stomach. And again, in order to really see the stomach, we have to dissect most of that fatty connection away, but just to show the location of where these structures would be. So the greater omentum down here, hanging off from the greater curvature of the stomach. So here's the stomach, and the stomach in some of these cadavers was really large, really distorted, which I found quite unusual. But the stomach should not be as big as we're seeing it here. It should be a little bit smaller, but chronic overeating can actually distort and enlarge and kind of really stretch out the shape of the stomach. So we see the stomach here, this large bag-like structure. Here's the greater curvature. And hanging from that greater curvature is where we find the greater omentum. Now, this is also helping to attach the stomach to the transverse colon. So beneath this fatty connection here, we would find the transverse colon as well, okay? And I've got another image just to show what that would look like. So here is what that greater omentum looks like. Again, this fatty connection, which is really the visceral part of the peritoneal cavity. Whereas in order to get into the abdomen, we have to distort or disrupt the parietal aspect of the peritoneal cavity. And then we can see its attachment here sort of hanging from the greater curvature of the stomach and also attaching to the transverse colon, which is found deeper here. So here's that transverse colon, which is being attached to the greater curvature of the stomach via the greater omentum. Okay, so let's get into the stomach itself and look at some of these structures. So we've got the greater curvature, which I'm pointing out here, or I've kind of already pointed out here, right? We've got the pylorus, which is this narrowed region that I'm sort of holding in my hand here. And again, the stomach was really largely stretched out, so some of this was sort of distorted. We've got the fundus of the stomach, this top sort of rounded portion. So the stomach is really this J-shaped organ. Okay, we can kind of appreciate that here. And this top part is the fundus. This is the greater curvature here, so greater curvature. This is the lesser curvature, which kind of takes that beam-like dip there in the medial aspect. So this is the lesser curvature. And here is where we would find the lesser omentum. So the greater omentum would be down here. The lesser omentum would be on top here, okay? We've also got the pylorus. I think I pointed out there that narrowing where we start to go toward the duodenum, which is into the small intestines. Yeah, and this is what the stomach would look like there, okay? And then this large, this large general region here is what we call the body. So we've got the fundus up here, the greater curvature, lesser curvature, the body, which is all of this, and then the pylorus. All right, let's get into some of the other visceral organs in the abdomen, as well as some of the vessels in the region. Now, again, you can really get a sense of how vast and sort of confusing and mobile and, unfixed these structures are. And so we really have to start moving things around in order to get a better appreciation of some of the deeper structures, as well as some of the lateral versus, medial structures here. So this view is giving us what the pancreas looks like. So here's the pancreas. And the pancreas runs across the central aspect of the abdomen. Okay, we're really gonna have to reflect. So this is the stomach that I'm reflecting here. So the pancreas is gonna be deep to or behind the stomach. And so we're really gonna have to flap it out of the way, move all of the intestinal contents lower in order to get a sense of where the pancreas is. So here's that pancreas. And one way to set it apart from some of the other organs is this kind of granular texture. It almost looks like a gland, kind of the way the parotid looked like. It actually is a gland, so it's going to give you that. It's going to have that granular sort of textured appearance, and that is one way to set it apart from things like the stomach and the other organs in the region. So it actually extends across here, and it's actually coming in contact with the spleen. So the spleen being that organ that helps to filter our blood, it's involved in the erythrocyte life cycle. And it's in the upper left quadrant of the stomach here. And the tail of the pancreas comes into close contact. In fact, they're inseparable. The tail of the pancreas is inseparable from the medial aspect of the spleen, okay? Excuse me. What we're seeing here are some of the colon, so the large colon we can see here, and I'll point these out later on, as well as some of the vessels in the region, right? So you can see a lot of the vessels in the region there. Okay. So we've kind of moved the pancreas a little bit lower. So here's that pancreas again, going towards the spleen. So this organ over here. There's that head of that pancreas, neck of the pancreas, body and tail, right? And then above that, we can now get a clear sense of our first abdominal vessel, which is the celiac trunk. So here's that main stump coming off of the abdominal aorta. And again, the abdominal aorta is going to be a bit deeper here. So we can't quite appreciate it, but it's descending, going from top to bottom through the abdomen. And the first branch that it gives off, that gives blood to some of the GI organs, is the celiac trunk, right? Which is really just the stump of a vessel. Coming from the celiac trunk, we have the left epigastric, Okay, left epigastric is going to be giving us the, giving blood, excuse me, to the stomach. We've also got the splenic artery, right, going toward the spleen, which really makes sense, right? And the splenic artery is sort of tortuous and windy. It's one way to really set it apart from some of the other vessels in the region. So here's that splenic artery going over towards the spleen. And then here is the hepatic artery going that way. Okay, and then that will then further divide into some other vessels that we don't have to worry about. So we've got the left epigastric, we've got the splenic artery, we've got the hepatic artery, all branches of the celiac trunk. Okay, moving down a little bit lower, here we're seeing the superior mesenteric artery, but again, in order to really move some of those visceral organs around, that has been cut. So we're seeing the cut surface of that superior mesenteric, and I'll show you in another image where we can see some of the branches. And then I'll show you another 3D model where we can better appreciate how this branches. And then we're also seeing the inferior mesenteric artery here as well. Okay, so the celiac trunk would have been behind the pancreas. Here's the pancreas again. This is in a different cadaver going across. Here's that bottom edge of the spleen. Here is one of the kidneys here. So this is going to be the left kidney, slightly higher than the right kidney. And these kidneys had a lot of abnormalities. They had a lot of large cysts. And cysts is not something that we quite understand how they come about, but this is kind of an interesting finding on this cadaver. A lot of large sort of granulated openings and cysts throughout the kidneys. And again, we're not entirely sure what brings this about. There is a genetic component in some instances, but again, just one of those interesting findings on this cadaver. So yeah, we've got the kidney here, left kidney, we've got this bottom edge of that spleen, we've got the pancreas running across. And just to talk about where the celiac trunk would be, because we can't sort of see all of them in one view, it would be behind the pancreas running across here. And then lower to that, we'd have superior mesenteric, the second major branch off the aorta. And we can see the aorta descending quite nicely here, the abdominal aorta. And then the third major branch being that inferior mesenteric artery. Okay, another view here, we've really kind of shifted everything upward to get a clear view of the bottom of some of these major vessels. Here again is that inferior mesenteric artery giving rise to the left colic artery. And the left colic artery is going to branch out and give blood to the left part of the colon, mainly the descending colon, which is on the right side, excuse me, the left side here, as well as the sigmoidal artery. And the sigmoidal artery goes even lower towards the sigmoid part of the colon. And then we can also get a sense of how the abdominal aorta eventually splits off into the right and left common iliac arteries, right? So we got the left common iliac, right common iliac, and then that will divide again into the internal iliac and the external iliac. Now the external iliac is what is eventually going to become the femoral vessels. It's going to cross the pelvic brim here, cross the inguinal region, and then become the femoral vessels, whereas the internal iliac is going to give us the blood supply towards our pelvic organs. We can also appreciate the inferior vena cava. So again, more of a collapsible venous structure here. It's been completely flattened to the vertebral column. So if you're not looking quite carefully, you may just think it's fat or connective tissue, but it is actually the inferior vena cava, which is on the left side, the right side of the abdomen. Here it goes. Whereas the aorta, much more of a patent structure, which we can appreciate here, is on the right side. Here's what some of the veins in the region look like. So the major veins that are draining from all parts of the colon eventually culminate and send that blood to the portal vein. So it's really important to grasp this understanding that the veins of the GI organs do not dump into the inferior vena cava. Very, very important connection to make. They must be filtered through the liver. All of the nutrients, the fats, all of the molecules that we've absorbed in the venous blood in the GI organs don't go back into the right side of the heart immediately. They have to go to the kidney, the liver first. So they eventually culminate into the portal vein. The portal vein goes into the liver. That gets filtered out. We can absorb those nutrients. We can, process fats and so on. And then we can send that blood through the hepatic veins towards the inferior vena cava and then towards the right side of the heart. So this is how all that blood coming from the GI organs goes towards the liver. We've got the splenic vein here. And again, I'm holding the spleen here in my hand. So the attaching, this is the splenic vein. And just for reference, we'll talk about that splenic artery, which is a bit more windy or bendy, as I mentioned. So that splenic artery accompanying splenic vein. And then the splenic vein joins with the inferior mesenteric vein. So here's that inferior mesenteric vein. And then both of those gets, joined with the superior mesenteric vein. So here's that superior mesenteric vein, and then they all dump towards the portal vein. So here's that portal vein, which is a little bit deeper to, again, the pancreas here, which is stretching across. Okay. So again, really important to make the connection that all GI venous blood has to go to the liver first via the portal vein here, and then it can be filtered, nutrients can be processed appropriately, and then that deoxygenated blood can be sent to the right side of the heart. And if you remember us speaking about this last semester, we talked about a portal system. And a portal system is any time we have deoxygenated blood that does not immediately go back to the right side of the heart. And so it's going to go from one vascular bed to another vascular bed in succession and then go back to the heart. And this is another example of a portal system here in terms of that GI circulation. All right, let's keep going. So here we're seeing a better view of the large intestine. And so the large intestine is where I can clearly show the different parts. The small intestine, which is kind of bunched up in here, it's very difficult to appreciate duodenum from jejunum, from ileum in sort of one view. And so I'm going to point that out probably a little bit better on a 3D model. But don't be expected to discern between duodenum, jejunum, and ileum. Rather, be expected to discern between large intestine and small intestine. And I'll show you some ways to do that. So here's the large intestine sort of encircling here. We've kind of spread it out here. And the small intestine is sort of, enveloped inside here. And the main difference between small intestine and large intestine is going to be the size, right? The width of the tube here is smaller than the width of this tube here. Another main difference is the fat. The large intestine is enveloped with all of these appendages. These are called epiploic appendices, which are basically just fatty connections that are on the surface of the large intestine, okay? We've also got things like the house straw, which I'll point out a little bit later on, but these outpouchings that make the large intestine appear more puffy, we can sort of see that here, as well as these fatty omental or epiploic appendages that are attaching to the colon as well. And then it's pointing out the parts of the colon here. So here's that ileocecal junction. This is where we go from ileum, which is here, to cecum, right? And then at the ileocecal junction, we're going to find the vermiform appendix. So here's the appendix. And if you've had your appendix removed, if you've had it inflamed or giving you any sort of trouble, if you know anyone who've had that, it's very, very painful, very, very unfortunate. And this is why we have to have it removed. It's not an organ that has much function. It's thought to be a vestigial organ. There's some literature or some sources that say that it has a role to play in the development of the immune system of the GI, but in older adults or in adult periods, it doesn't have a clear function. And so if it starts to get inflamed, usually from bacteria that's coming through the colon, we just simply remove it, but it can cause a lot of peritoneal irritation, a lot of inflammation, a lot of pain, fever, vomiting. It can be very, very uncomfortable, very painful. And if you know someone who has had that removed, I'm sure you can attest to that. So here's that vermiform appendix. And this has a lot of variation. Sometimes it's smaller, sometimes it's bigger, sometimes it's shaped differently. There's a lot of variation with how the appendix looks. And then from this ileocecal junction, where we have the ileum becoming the cecum, we then go to the ascending colon, which goes up this way. We then take the turn. So this turn is called the hepatic flexure, right? Also called the right colic flexure. We go to the transverse colon running across here. And then we have the splenic flexure, also called the left colic flexure. And then we go to the descending colon, eventually to the sigmoidal colon, which you can kind of see here, taking more of a windy or bendy turn. And then we go back into the pelvic cavity where we have the rectum. All right, so the cecum, the ascending colon, the transverse colon, the descending colon, the sigmoidal or S-shaped colon, and then the rectum. And then we have the hepatic flexure here where the colon takes a turn from ascending to transverse. And then the splenic flexure here where the colon takes another turn from transverse to descending. Okay, here is a closer look at the colon. And again, getting to appreciate some of the colic structures. So the colon has these outpouchings, these are called the haustra. And this is because of this band-like structure that runs longitudinally, which is the tinea coli. And the tinea coli is this fibrous band that kind of gathers the central part of the colon. So think about you running an elastic through your pants. And because of that, that central tendon, it develops this gathering, which is what creates the haustra, these outpouchings or outpockets. We've also got these epiploic appendices, again, these fatty-like appendages sticking off of the sides of the colon, which are some ways to distinguish it from other structures, the small intestine. Okay, some other structures here quickly, we've got the falciform ligament, right? So here's that falciform ligament, which is separating the quadrants of the liver. So here's that right quadrant, here's the left quadrant, sort of behind my hand. And then coming in between is the falciform ligament. The very ending of the falciform ligament is the ligamentum teres, also called the round ligament. So they're kind of one continuous structure, but the different parts of the structure. This part is the falciform, this part is the round ligament or the ligamentum teres. And then lastly, I'm going to show you a little bit of the gallbladder, but the gallbladder was not very good this semester. In fact, 3 of our cadavers had their gallbladders removed. And so it's really tricky to get a good appreciation of some of the other structures. But we can see the gallbladder here sort of tucked into the undersurface of the liver. So here's the liver, right? Here's that gallbladder sort of tucked in there. And we can see that it has bile, right? This green discoloration, this green pigmentation that we're seeing is from all the bile that is involved in the region here. This is the cystic duct. So the cystic duct goes toward the gallbladder. And then we've also got the common hepatic duct. These two structures merge together to give us the common bile duct, which goes towards the second part of the duodenum, right? The duodenum where we can dump that, those secretions into the duodenum. So the gallbladder is really just about storing bile, whereas the liver is what makes the bile. So the liver makes the bile, sends it down via the common bile duct. We've got right and left hepatic ducts coming from both lobes of the liver. That merges to form the common hepatic duct, which is how we bring that bile down from the liver. We can then send it towards the gallbladder to be stored by the cystic duct. So this is the cystic duct. And then when that needs to be released from the gallbladder, we communicate it to the common bile duct, which is the common opening toward the duodenum.